Here is a chest radiograph on 55-year-old who presented with history of cough and shortness of breath. So if this case is presented in viva voce of radiology exam, how do you proceed? First of all, we need to describe the radiological findings in detail before coming to any differential diagnosis or conclusion. The way to describe the lesion in viva voce is something as follows. Here is a frontal chest radiograph on 50-year-old. The chief findings are widely distributed, extensive, ill-defined, patchy opacities in both lungs involving all zones, predominantly in the right lower zone and in the left perihilar region. The opacities are ill-defined and there is no evidence of pulmonary nodule or mass with speculation. No air bronchograms are seen, no evidence of bronchiectasis. The lung volumes appear smaller, presuming the radiograph is taken in deep inspiration. The costophrenic angles appear clear. Despite AP projection, there seems to be cardiomegaly. The hila appear bilaterally bulky or enlarged with loss of demarcation of the hilar structures and the right descending pulmonary artery. The superior mediastinum appears prominent, but the findings are quite non-specific to comment on true mediastinal widening. Apart from moderate degenerative changes in the right acromioclavicular joint, the bones and soft tissues appear normal. So these are the radiographic findings. So based on this, I would proceed with my inference. Based on these above findings, features are likely to represent long-standing changes, such as chronic interstitial lung disease. However, acute presentation with extensive fulminant pneumonia can give similar appearances, but I note the patient is not intubated or there is no central line. I would expect that to happen in fulminant pneumonia. Other differentials would include lymphangitis carcinomatosa with pulmonary metastasis, but I do not see any fairly well-defined pulmonary nodules to support the diagnosis. Most importantly, I would like to view any previous radiographs, especially which are performed a few weeks, few months, or years earlier. And at that moment, the examiner might provide a previous radiograph which was done about 8 years ago. So here we have a previous radiograph from 8 years ago, which shows an ill-defined, non-homogeneous opacity in the right lower zone, which is present on the current radiograph as well. On the previous radiograph, again, both hila appear bulky with most likely right lower paratracheal mediastinal enlargement suggestive of lymphadenopathy. So based on these findings, features are likely to represent progressive sarcoidosis. Other differentials of tuberculosis is less likely given no cavitations or extensive consolidation or fibrosis in 8 years' time. I would like to confirm the diagnosis by performing a CT scan of the chest, especially the HRCT of the chest. So when we perform HRCT, the examiner might show the HRCT findings, and you can tell that there is extensive bilateral diffuse thick interlobular septal thickening with extensive ground glass opacity with some mosaic pattern, and also there is bilateral moderate to extensive cicatricial bronchiectasis. On the mediastinal window, there are multiple enlarged peripherally calcified, fairly symmetrical lymph nodes in the paratracheal regions. Hence, the diagnoses are confirmatory or very characteristic of sarcoidosis. It is very important to note dilatation of the main pulmonary artery, that this patient has got pulmonary arterial hypertension as well. So, in summary, we have got a very complex chest radiographic appearances, and we need to describe the radiographic findings, and then we need to arrive with various differential diagnoses, compare with the, suggest the right next investigation, and review the HR